Hello, everyone, and welcome to our first of 5 lectures on ONG common presentations that you'll see in your 4C rotation. My name's Mark, and I'm joined by Georgia, and Sophie has also helped us with this presentation as well. Today, we're going to be talking about abnormal uterine bleeding, and this lecture and the rest of our lectures are proudly sponsored and supported by QUESMED. We're going to now play a quick video telling you a little bit about QUESMED, and then we'll get started with the lecture. Thank you.
QUESMED is a next-generation question bank that integrates high-quality questions with Anki-style flashcards, as well as a comprehensive reference textbook backed by cognitive and educational research to help try and make learning more efficient and help you know exactly what you need to know to pass your exams. Hi everyone, my name is Priyesh and I'm currently QUESMED's Digital Teaching Fellow. Today I'm going to give you a quick tour on how to get the most out of our platform. So once you've bought a subscription and you've entered the QBank platform, the easiest way to start doing a set of unseen questions is hitting our quick start button. Then you'll see that for each question we have detailed explanations on why each answer is correct or incorrect, and we also have a page associated with each question. This goes into depth on everything that you need to know for that condition. Next, I'd like to show you our flashcards. And these are based on an AI algorithm which takes into account the questions that you've got wrong and need to learn further to produce a daily set of flashcards which you can then rate to then further help determine what you need to see on the next day. And as I mentioned, these refresh every single day. We have mock tests on our platform as well, including prescribing assessments. And as mentioned, we have a detailed knowledge library, which is a textbook covering exactly what you need to know for your exam for each condition. For example, acute coronary syndrome, where we have a summary followed by all the important aspects of the condition, including references at the end. We also have videos which cover tutorials as well as lectures. And just to quickly show you, we also have an OSCE which will cover the practical elements of your exams, including A to E assessments, communication skills, examination stations, and history taking stations. So for example, with each and every station, we can take them under timed conditions, and this is something that you can do with your friends where you can each take up a role and you can practice and go through them together. And for each OSCE station, we also have a walkthrough on how to approach that station as well. So that's everything that I wanted to cover today. That was a whistle-stop tour. If you have any other questions, please email us at info@quesmed.com, and I hope you found that useful. Thank you for watching.
I'm Georgia. So some of the matrix items we're going to be talking about and covering today include leiomyoma, endometrial polyps, adenomyosis, and postmenopausal bleeding, which are all common differentials when thinking about abnormal uterine bleeding. Just a disclaimer before we get going, these are student-created lectures, and as we know as students, we don't always get this right. So please be patient with us. If you do happen to notice some discrepancies or some errors in our presentation, please let us know. So to start off, what is abnormal uterine bleeding? Abnormal uterine bleeding is ultimately described as any discrepancy or alteration in the normal functioning of the cycle. And what we mean by normal is a regular period with 7 days at maximum bleeding without sort of any clots or extremely heavy bleeding and without sort of any significant pain or discomfort to the person who is menstruating. Things can be abnormal if they vary in the frequency of how often they occur. So for example, if they're having very, very short or very, very long or irregular windows between periods. If the duration of these periods is excessively long, sometimes it can also be if it's short, but it's more likely to be longer than usual that we start to worry about things just because of that blood loss and how much a patient is dropping their iron stores and their hemoglobin. The regularity of this bleeding, so whether or not this is every 28 days, if there's a few days variation either side of that, or if someone is having extremely long periods between their periods. The volume of bleeding is also something that can be considered abnormal, particularly if people are having very, very heavy periods, particularly with things like clotting or tissue in the bleeding. The other time bleeding can be abnormal from the uterus is if someone is postmenopausal, as we do not expect someone to be bleeding once their normal cycling has stopped. So some of the ways we can break down abnormal uterine bleeding is by thinking about the differentials according to the Palm-Coyne mnemonic. So this breaks us off into the structural and non-structural causes of abnormal uterine bleeding. So PALM, the first part, represents all the differentials we like to think about from a structural perspective of abnormal uterine bleeding. So this can be things like polyps, where there's sort of outpouchings like we see here in sort of this first little bulge that's coming out of the endometrium that can be contributing to abnormal or irregular bleeding. There's adenomyosis, which is growth of endometrial tissue into the myometrium or the muscular lining of the uterus, which can also be abnormal. There's also leiomyomas, also more commonly known as fibroids, and these are sort of smooth muscle collections in little kind of cysts that sit in the wall of the uterine organ, as well as commonly just below the endometrial layer, or sometimes just on the outside of the uterus. We also worry, obviously, about our red flag of malignancy or hyperplasia, particularly endometrial cancer, which is common in postmenopausal women who have abnormal uterine bleeding after they've ceased menstruating. These often can all be diagnosed via histopathology or imaging. So that's where our first port of call is. We think about, can we do an ultrasound or can we take a biopsy from the person who's having abnormal bleeding? In terms of the next part of the acronym COIN, this is our non-structural causes. So these are things that aren't identifiable from an ultrasound or a histopathology imaging, and are something else we might need to run some more specialized tests or think more broadly about. To start off with, the C stands for coagulopathy. It makes sense that if someone has a coagulative disorder where they can't clot or they are more prone to bleeding, that they will then have issues with heavy bleeding or more frequent bleeding. These are commonly in people that have a family history of clotting disorders or are having some kind of change in their clotting factors. There's also the ovarian disorders that we need to think about. So these can be things like PCOS, which causes really infrequent and irregular bleeding, but also things like, ovarian cancer and other things like that, which are probably less common for abnormal uterine bleeding, but can still occur. Then we think about things like endometrial disorders. Could this person have something like endometriosis? We then think about iatrogenic. So these are things like, does a person have an IUD in situ, which is meaning they're not menstruating? Have we given them something like a rod, which means that they are bleeding for a prolonged period of time while their body adjusts to these new levels of hormones? The last differential we think about is not otherwise specified. And this is probably something that you're going to refer to more senior clinicians or specialists about. So as we've talked about, we can use Palm-Coyne to think about the uterine and endocervical causes of abnormal uterine bleeding. It's also important to know that in some cases, the bleeding source can be from further down the vaginal canal or around the vulva. So in these instances, we can have cervical atropions, so that's little changes to the cervix, where some of that rich endometrium from the inside of the uterus becomes extroverted outside of the uterus a little bit. And that can mean, because it's more vascular and has a higher turnover as with the rest of the endometrium, it can mean that this person experiences more bleeding when things come into contact with the cervix. So this can be while inserting tampons, this can be also while having sex. There's also the probability and possibility that someone can be suffering from an STI and is having some bleeding as part of that. There's the potential that the abnormal bleeding can be due to trauma in the area, as well as pregnancy. So thinking about your early pregnancy bleed, red flags. So things like an ectopic pregnancy or even something like a miscarriage. So to kick us off and to kind of consolidate some of these concepts, we're thinking about Marty, who's a 30-year-old female and presents to you with heavy menstrual bleeding for the last 12 months. So I'm going to involve Mark and to give me a hand with this case. So Mark, what do you want to know about Marnie?
So for Marnie coming in, I think there's a few different histories that we want to take. We'd like to take a period history initially. And then I'd want to know a little bit about her sexual history, a broader obstetrics history, and then a gynecological history. And if I have time, I would expand that out with a general medical history. But for the sake of this lecture, let's just focus on the first few. So the first thing related to periods I'd like to know is how heavy the bleeding is and if it's having an impact on her life. A good way to ask this, I think, is how often is the patient changing pads, or if she's noticed any clots, and is it substantially different to what she's used to? On that topic as well, I think it's also important to understand how often this bleeding is occurring and for how long. Whether there's bleeding that occurs between periods, whether the periods are regular or irregular. I think it's also useful to know if there's any pain or other symptoms that are different with the period. And this is something where we're trying to specify what a baseline is and what the new presentation looks like, as well as understanding if the patient has started menopause, and if so, when that happened, and also the age of menarche, which is the first period the patient had. And then finally, I'd like to know the date of her last menstrual period.
Yeah, I think they're all really important things to ask, Mark. So good work. I think if people can have a think about maybe what they would want to ask, if there's anything else that they would be concerned about and wanting to determine from Marnie's history, that would be a really good thing to think about as well as you're listening. So when it comes to taking period histories, it can be quite challenging to know where to start or what to think about. So I like to break it down into the following. I like thinking about how heavy the bleeding is at the start. So how often is a patient changing pads? Are we talking, once a day, twice a day? Are we talking every hour or 2 hours? If someone's changing their pad every 1 to 2 hours, that's quite abnormal. They shouldn't be changing their pad that frequently. It should be at least sort of 3 to 4 hours. You can also ask about if there's any clots. So often with clotting in a pad, especially during periods, that's an indication that someone is having quite heavy bleeding. So that's always a good thing to ask about when trying to determine how much is someone bleeding and how worried should I be about the amount of bleeding they're having. Another thing which I think gets commonly overlooked is the impact that heavy bleeding is having on someone's life. Because we know that, periods happen on average for, most people who menstruate about once a month. And if you're having a period of 7 days every month or so where you're bleeding and it's meaning that you can't go into the office or you don't feel confident doing the activities you normally do, that's having a pretty substantial impact on someone's life. You then want to know, okay, how often is this heavy bleeding happening? Is it happening all the time? Because that's going to make you really worried about, are they anemic? Is this something I need to do something about quite urgently? Or is this only sort of once or twice a year? And then you want to know how long as well, because that's going to contribute to your evaluation of how much blood they're losing and whether or not you're concerned about their anemia. You then also want to know if there's any bleeding between periods. And this can be really tricky to differentiate if this is in itself a period and if the periods are irregular versus is this just a random bleed that's happening between periods. So really trying to nail down with people how regular are these periods and when is the bleeding occurring and for how long. You then also want to ask how regular they are, because that's going to give you some important information about how their cycle's going and how much bleeding they're having as well, all up. Another thing to ask about is any pain or other symptoms that go along with the period. This is particularly relevant for things like endometriosis or dysphoric premenopausal syndrome. So these are things that cause substantial impacts on people's lives and comes back again to the impact their period is having on their lives. We then also want to know, like Mark said before, the age of menopause or menarche, and then the date of their last menstrual period. So Mark, with Marnie, she reports that she bleeds quite heavily. And when we questioned her about this, she said that she's been using pads and tampons together because often she leaks through the tampons in a matter of hours. She finds that she needs to change her pad and tampon every hour and even sets alarms in the middle of the night to change her nighttime pad. This kind of points that she's having quite substantial bleeding. We also find out pretty quickly that the periods are having a pretty significant impact on Marnie's life. She's been calling in sick to work because she's worried that she's going to bleed through her pad and tampon during her commute. And towards the end of her period, she manages to get to work, but she can hardly get anything done in the office because she's constantly anxious about leaking. In terms of her cycle itself, it's a fairly standard 28-day cycle with 7 days bleeding and a regular cycle, so sort of every 28 days. She denies any intermenstrual bleeding. She said that it's usually about 6 days in length. And she said that she doesn't really have any symptoms or pain that go along with her periods. She said that her last period was about a week ago. All right, so Mark, we might think about her sexual history next. Is there anything you'd like to know in particular?
So with her sexual history, I think that we need to firstly ask Marnie if she is sexually active, and we shouldn't make any assumptions. So that would be asked in a non-judgmental way. And then we would want to really know about the type of partner and relationship she's having and the number. Then I think you can start asking about the type of sex, whether it's vaginal, oral, anal, or other. And then once you have that information, you can start thinking about whether she's using any contraception, what kind of contraception is being used, whether it's condoms, whether it's an IUD, something like that. And you'd also want to understand if she's had any screening for STIs or had any STIs in the past, and whether she knows about the status of her partner's STI status. And in addition to that, this is a good opportunity to also ask in a history about her attitude towards sex, if she feels safe during sex, and also asking whether there's any pain or discomfort during sex that it's new or abnormal for her.
Right. I think that's a great summary of everything to ask. I think, like you said, the number and type of partners is going to make you think about, is this person at risk for an STI, and how intensely and what type of STI testing we should be doing for this person. Types of sex is also quite important in terms of where you will look for an STI and what sites you will consider taking swabs from. For example, commonly people with cervixes and vaginas get vaginal swabs and testing and urine specimens, but often oral and anal swabs can be missed. So I think it's just important to remember to ask this question and remember that people have sex in different ways, and it's important to not make assumptions. I think pain during sex is also a very important one that's commonly not asked, I think, because people feel uncomfortable asking it, as well as attitudes to sex. But this can tell you a lot about, again, what people might be worried about and the effect these things are having on their lives, because intimacy is important to a lot of people, and ultimately not being able to have sex or having discomfort during sex is going to impact someone's self-confidence and happiness a lot more than some of these other symptoms. It's also important to think about protection. And when we say protection, specifically condoms as well as other means of contraception. So condoms protect against STIs, whereas the other hormonal agents usually don't. So I think it's very important to be aware and think about, is this patient protecting themselves against STIs or just pregnancy? And then again, previous STIs or screening is also important, particularly amongst young patients, because this is going to broaden your net and your, I guess, suspicion on whether or not they could have an STI. And as a side note, although this presentation sort of isn't really as much to do with an STI, and it's probably less likely given that her bleeding has been there for so long, it is really important to still ask these things in patients, especially if they are sexually active or young, because we find those people are most at risk for an STI. And for a lot of people, the only time they get diagnosed is when they are screened, because often they are asymptomatic. So please don't forget to ask your sexual history questions. So in terms of Marnie's sexual history, she said that she's sexually active with one partner who's male and her husband. She's previously had both male and female partners, but now only has one. She had penetrative vaginal sex only, and she actually mentioned that over the last 6 months, she's had quite deep pain on sex, which is causing her a lot of distress and making her quite unhappy. She said that she's only using condoms for contraception, and at the moment isn't on any hormonal agents. She also says that she hasn't had any STI tests in the past, and she's never been diagnosed with one. What other important information might you want to know, Mark, about her ONG history?
I think that we've got a lot of really good information so far. Some other things that would be important are obstetric history. So understanding if Marnie has ever been pregnant, whether she has delivered children, alive children, or whether she's had any miscarriages or stillbirths. And the timing of asking that question is very important because they're classified differently depending on whether it's before 20 weeks or after 20 weeks. We also really want to understand any family history, which is particularly important. Georgia, you talked about bleeding from blood clotting disorders, things like von Willebrand's disease, very important to pick up. And this may be the first time that it's noticed in this patient that they may have inherited a bleeding disorder. So understanding family history of medical disorders, any family history of cancers, any family history of gynecological conditions is very, very important. In addition, you also need to do a complete surgical history and medical history, and also understanding if the patient is currently up to date with her CST screening, medical screening test.
I think you hit the nail on the head with the CST, particularly if the patient is between 25 and 74 years old. Like you said, it's also important to think about surgeries and diagnoses in the past, both medical and obstetrical gynae. Pregnancy history, like you said, is very, very important, especially when thinking about what the causes of abnormal uterine bleeding are. For example, something like adenomyosis is far more common in someone who's had previous C-sections or gynecological surgery compared to people who haven't. So that can really clue you in about what a patient might be more likely to have and your risk factors. And like you said before, your family history, especially for things like cancers and clotting disorders, are really important to think about when you're doing your abnormal uterine bleeding. So in terms of Marnie's history, she tells you that she's never had a CST despite being 30 years old. She also says that she's never been diagnosed with any gynecological issues or had any surgeries in the past. She's had no previous pregnancies and hasn't delivered any children. And she's got no relevant family history of cancers or clotting disorders or anything else that of concern. So next step for Marnie will be thinking about where do we go to from here. Generally, we do our history and then we do our exam. It's important to know that all of your gynae and obstetric exams are very invasive, and it's important to consent your patients properly and consider having a chaperone with you nearby as well. So what do we think about we want to do with Marnie?
I think that the most important thing initially is going to be doing a CST, a cervical screening test, if the patient has consented to that. And also an STI screen could make sense as well. There would be some bedside tests. And then I think in terms of, we would do a number of bloods, and I think also imaging is really important, and a transvaginal ultrasound could provide some answers towards what is causing this bleeding.
Yeah, I think they're all really good points. I think doing a bedside speculum exam so you can have a look at the cervix is a really good place to start, like you said. So looking to see if there's any abnormal discharge from the cervix that could indicate maybe an STI, as well as whether or not there's any ectropion visible, or if there's any clots or other things coming out of the vagina. I think that's a great place to start. And like you said, it gives you the opportunity to do all your screening tests and your opportunistic investigations, such as your CST and your STI screening. I think it might also be helpful if we have Marnie's consent to do a bimanual exam, just so we can make sure we can see if there's any intrapelvic masses or if the uterus feels particularly boggy or enlarged. I also agree that we should probably do some blood tests and some imaging from here as well. So the investigations we end up ordering for Marnie include the CST and the STI screen, as well as an FBA and iron studies, just because we are worried, given her long history of quite heavy bleeding, that she might be anemic. We also then order a transvaginal ultrasound as well. Some things we could consider probably down the line if these investigations came back as negative or we couldn't find a cause based off these would be things like TFTs, looking for hypothyroidism, which can lead to things like heavy or frequent bleeding as well as fatigue. And then hysteroscopy D and C, if we're particularly worried about some sort of endometrial metastasis or other cancer. And potentially a laparoscopy if we are concerned about things like endometriosis. So Marnie's results come back as the following. Her CST is found to be negative, and they are happy for you to repeat this in 5 years with her GP. Her STI screen also came back negative, which you happily informed Marnie of, and you advised her that if she does change partners in the future, or if she starts having sex with other people, she should probably consider having a repeat STI screen. Her FBA and iron studies show that she had iron deficiency anemia. So you organise an iron transfusion as well as some ongoing supplementation for Marnie. Her transvaginal ultrasound found that she had 2 submucosal fibroids, each measuring 2 centimetres in size, but no other abnormalities besides this. When we're thinking about fibroids, these are ultimately little outpouchings of blood vessels and endometrial tissue that sit in sort of 3 places possibly. So the first place that they can sit is in the lining of the endometrium, and that's sort of your type 1. And these are pretty common, and these are known as your submucosal fibroids. There's also your intramural, and these are little smooth muscle segments that sit in the uterus wall. In some cases as well, you can also have subserosal, which ultimately sits under the perimetrium, or the outmost covering of connective tissue that encompasses the whole uterus. So ultimately, the one that's most likely to cause menorrhagia, which is defined as heavy menstrual bleeding, is your submucosal. And given that Marnie does have a submucosal fibroid, it's pretty likely that this is the cause of her symptoms. So from here, I think the most important thing we tell Marnie is that because her fibroids are 2 centimetres in size, which is less than sort of the cutoff of 6 to 8 centimetres, we probably are happy just to manage her symptoms for now, and she probably won't require any definitive management at this stage beyond monitoring. So generally with fibroids, we say the cutoff is about 6 to 8 centimetres. And above this, we start to think about things like myomectomies, uterine artery embolization, or hysterectomy, which are all your surgical interventions. So we tell Marnie that because the fibroids are 2 centimetres in size, we'll just keep monitoring this every year or so to make sure they're not increasing in size. And for her problems with her ongoing periods, we might consider something like a progesterone-only pill or an IUD, depending on which you prefer and what is more acceptable to her. We also will probably consider things like TXA on the first day of her menstrual period, especially because her periods are so predictable and she can take these sort of 12 hours before her bleeding begins as a way to stop that pretty intense bleeding. We also might suggest things like NSAIDs, which might be able to help with pain and bleeding. And these are the guideline recommendations for these. If we find that Marnie's symptoms aren't controlled with these interventions, or that we find the fibroids increase in number or in size beyond the guidelines of sort of 6 to 8 centimetres, we might consider referring her off to a gynecologist for one of the following procedures. So first off, there's the uterine artery embolization. And this ultimately is where they flick a little embolus into the artery or segment of the artery that's supplying that portion where the fibroid is. And that restricts its blood flow and ultimately means that the fibroid won't bleed as much. We can also do a myomectomy, which is where they remove partially that segment of smooth muscle tissue, which is contributing to the fibroid. And ultimately, this is probably the best one in Marnie's case if she wishes to have children, because it preserves fertility, whereas some of the others don't. The final option, which we're probably less likely to do in Marnie at this stage without trying the other alternatives, is a hysterectomy. And this is just because of fertility concerns, but also for things like prolapse and incontinence in the future. So that's the end of our first case. All right, take us away with the second one, Mark.
So let's do our second case. So Judy, who is a 64-year-old female, comes to the clinic and she is presenting with sporadic episodes of light bleeding postmenopausally. She says that she doesn't have any pain. And in addition, you ask her a little bit about her gynecological history, and she tells you that she has not had any hormone replacement therapy. And she doesn't really have any notable gynecological or obstetric history. Her past medical history is that she has hypertension and type 2 diabetes, and her medication history is she's on lisinopril and metformin. So, Georgia, putting you on the spot here, what kind of differentials do you think could cause this postmenopausal bleeding?
I think there's probably a few things I'm thinking about, but given that she's postmenopausal, the thing I'm probably most worried about is an endometrial carcinoma or potentially hyperplasia. The other thing that usually pops up quite frequently is atrophic vaginitis, so that atrophy of the vulva and vagina after menopause. They're probably the things I'm thinking about prominently at the moment.
Yeah, and that's exactly what we're thinking. We also thought, endometrial carcinoma would have to be top of the list. And that's because it's the red flag condition you can't miss in a postmenopausal woman presenting with bleeding. In addition to that, we have endometrial hyperplasia, which we'll talk a little bit more. It can be both simple and atypical, where atypical has quite a bad prognosis moving towards endometrial carcinoma, so needs to be treated. The most common that you'll see a lot in the gynae clinics is the atrophic vaginitis in particularly older women and patients presenting to gynecological clinics. They have less estrogen, and because of that, they can have some atrophy of the vagina because of local trauma. It could be because a estrogen pessary is there, or perhaps there's the friction in the vagina because it's less lubricated. Things like that can cause atrophic vaginitis as the patient gets older. And then finally, differential is polyps as well. So there's a few things it could be. I guess the question we have to ask next is, given all of this, what is the best test to order? Do we do bloods? Do we do an ultrasound? Do we do a biopsy? There's a lot of different options, and have a think about that. What I was thinking was that the best test might be to order a transvaginal ultrasound as the next step. Let's have a talk now about endometrial cancer. So this is the red flag condition that we're really worried about. Georgia, do you have any idea about what some risk factors for endometrial cancer might be?
Yeah, I think the biggest one that I can think of is probably being postmenopausal. I haven't really ever seen it in a premenopausal woman, whereas every patient that I saw in gynae clinic, they were all worried if they had abnormal uterine bleeding and postmenopausal bleeding about endometrial cancer. Another thing I've heard is if they're on estrogen or estrogen-like agents. So particularly if patients are on HRT, that's commonly a risk factor for endometrial cancer, as well as things that mimic estrogen like tamoxifen.
Yeah, that's really good. That some of the theory is that the longer you are exposed to estrogen throughout your life, the more likely you are to develop endometrial cancer. So some of those risk factors to think about are things like nulliparity, not having children, because during the period of being pregnant, you have progesterone levels which rise as well. So you don't have as much exposure to estrogen during that time. Another one is obesity. And that makes sense because estrogen is converted peripherally from androgens to estrogen peripherally in fat cells. In addition to that, having starting periods early menarche, it makes sense you're having a longer period of estrogen exposure. And then also starting menopause quite late as well. You rightfully said as well, patients that are taking tamoxifen, which is an agonist at the uterus, can increase their risk. And interestingly enough, patients that have taken tamoxifen are more likely to have hyperplasia already. So a transvaginal ultrasound is less useful in this population, and they may need to go straight to other methods like a hysteroscopy and biopsy for a diagnosis. And then also, we also talked a little bit about the fact that someone who is on HRT or hormone replacement therapy may, for a period of time, have breakthrough bleeding, but that certainly isn't something to exclude endometrial cancer. That would be an explanation after ruling everything out. So we went and got that transvaginal ultrasound, and it actually showed a thickened endometrial lining of 8 millimeters. Now, from what we've seen, the thicker an endometrium is, the more likely the patient has hyperplasia and it's abnormal. Because of that, a biopsy is indicated. There's no exact cutoff, but some texts say between 4 to 8. There's no exact answer. And I would be surprised if you got asked a specific question about that because there's no real consensus. But given that it is greater than normal, and the patient is postmenopausal, a biopsy would need to be performed as well. The biopsy gives the diagnosis, and it's usually done with a hysteroscopy and biopsy being done through a gynecologist. So now I just wanted to quickly talk a little bit about the management. So there's a few different conditions that can cause postmenopausal bleeding commonly, and I think it's high yield to know what some of the management for them are. So for atrophic vaginitis, the treatment is local estrogen. It's usually delivered by a topical cream or a pessary that's inserted. Endometrial polyps, these can be removed under direct visualization during a histoscopy. So that is usually done by like a gynecologist. Cervical polyps can be removed by speculum examination using polyp forceps. However, this can also happen during a histoscopy as well. Atypical hyperplasia, so if hyperplasia is detected but it's not cancer, in a situation like this, there's a significant risk that this could progress to malignancy. So it's typically removed. The hysterectomy is the definitive treatment for this. And in terms of endometrial cancer, this is when you have a total abdominal hysterectomy, you have a bilateral salping oophorectomy, as well as washings, and you can also have radiation as well. And that's probably would depend on the oncologist or the gyne-onc consultant about the staging. But I think for the exams, what's really high yield to know is that you would need to do a hysterectomy for both of the last two cases. So that sums up our first presentation. Any final words, Georgia?
Just if there's any feedback, please let us know. We're always happy to take on some advice and improve things for you guys. But thank you for joining us.